Welcome. Today we'll discuss cognitive disorders and their significance in EMS. We'll compare acute cognitive disorders like delirium or acute confusional states with chronic disorders like dementia. Our focus is on pre-hospital care, recognizing altered mental status, effectively interacting with these patients, and considering safe transport. We'll keep it practical with real EMS examples and cover just enough neuroanatomy and pathophysiology to understand what's happening in the brain. By the end, you should be better prepared to identify when a patient's mental status is abnormal, differentiate delirium versus dementia, and manage these situations with confidence in the field. Let's get started. Cognitive disorders are highly relevant to us as EMS providers. With an aging population, we encounter many older patients on our calls. Studies show that a significant portion of ambulance calls for seniors involve some form of cognitive impairment. One analysis found dementia noted in roughly 14 to 21% of patient care records for those over 75. That's 1 in 5 older patients, a pretty substantial number. It matters because altered mental status can indicate something serious is going on. For example, delirium often means there's an underlying medical problem like infection, low blood sugar, stroke, etc., that needs urgent treatment. If we write off a confused patient's behavior as normal for them without investigation, we might miss a life threatening issue. Unfortunately, delirium is underrecognized even in ERS. Over 70% of delirium cases are missed. As EMS, we have an opportunity to catch these changes early. Recognizing cognitive disorders in the field helps ensure patients get the right care faster. It also helps us treat and transport them safely while preventing further harm. In short, this topic matters because it's common, it's high stakes, and we play a key role in identifying and managing it. Let's define altered mental status, AMS, in the broadest sense. AMS means the patient's level of consciousness or thinking is not normal. This could mean the patient is not as responsive as they should be, for example, lethargic or unconscious, or it could mean they are awake but confused, not thinking or behaving appropriately. It's a spectrum. On one end, you might have a completely unresponsive patient, very obvious AMS, and on the other end, you might have a patient who is awake and talking but saying odd things or seems disoriented. That still counts as altered mental status. In the field, we often start by using the APTO scale to quickly describe a patient's level of responsiveness. Are they alert? Do they respond to verbal stimuli, painful stimuli, or totally unresponsive? If they're alert, we then assess how oriented they are. Typically, we ask if they know who they are, person, where they are, place, what time or day it is, time, and what's happening, event or situation. A patient who can answer all correctly is alert and oriented times 4. If they miss some, say they know who and where they are, but not the date or what's going on, that's A and O times 2, which indicates confusion. In practice, if someone is awake but cannot correctly answer these basic questions, we consider them confused or altered. AMS has many possible causes. Think of the mnemonic AEIOU tips, which reminds us of various categories: alcohol or drugs, epilepsy or seizures, insulin or blood sugar issues, overdose or oxygen lack, uremia, renal issues, trauma or head injury, infection, psychiatric causes, stroke, and shock. In our context today, we're zooming in on cognitive disorders, particularly delirium and dementia, as causes of altered mental status. But keep in mind, when you meet an altered patient, you have to consider all possibilities. Often, delirium might be the consequence of one of those other problems, like an infection or low oxygen. So, AMS is a general umbrella term. We'll now clarify what delirium and dementia mean under that umbrella. Delirium is basically acute brain failure. Just like acute heart failure, sudden pulmonary edema, or acute kidney failure, the brain can acutely fail to function normally. That's delirium. It's characterized by a rapid onset of confusion and inattention. A patient who was fine yesterday or earlier today might suddenly be very disoriented now. A key aspect is that it often has a fluctuating course. Their clarity can wax and wane. For example, a delirious patient might be incoherent and agitated one moment, and then a bit more lucid 30 minutes later, then back to confused. This variability is a hallmark. In contrast, purely psychiatric issues like chronic schizophrenia or dementia don't usually fluctuate so dramatically hour to hour. Clinically, what do we see? In delirium, patients have trouble paying attention. They might not be able to follow your questions or may be easily distracted. Their orientation is off. They may not know where they are or what time it is. Their thinking is disorganized. They might ramble nonsensically or say things that don't make sense. They may even have hallucinations or delusions. For example, a patient with delirium might suddenly accuse you, the rescuer, of plotting to hurt them or claim they see insects on the wall that aren't real. They can also be very emotional, anxious, fearful, or combative. That's the hyperactive type. On the other hand, some delirious patients are just very sleepy, withdrawn, and hard to arouse. That's hypoactive delirium. Those are dangerous because we might just think they're quiet or depressed and miss that they're actually delirious. Always remember, delirium is not a disease on its own, it's a syndrome caused by something else. It could be an infection like sepsis or a urinary tract infection, very common cause in elderly, a metabolic problem like low sodium or high CO2, hypoxia, hypoglycemia, drug overdose, or side effects of certain meds like opiates or anticholinergics, or even just uncontrolled pain or urinary retention. In short, if you find a patient has delirium, you must search for what's causing it because treating that cause, antibiotics for infection, oxygen for hypoxia, dextrose for low sugar, is how you resolve the delirium. Lastly, delirium is serious. It's sometimes called acute brain failure in medical literature because it's as serious as heart failure or kidney failure. Patients with delirium have higher risks. It's associated with longer hospital stays, higher healthcare costs, and increased risk of complications and death. So, in EMS, recognizing delirium means you've identified a red flag. This patient needs prompt medical evaluation and treatment. Our job is to start that process by recognizing it, keeping the patient safe, beginning initial treatments like managing ABCs, checking glucose, etc., and alerting the ED that we suspect delirium and its possible cause. Now let's contrast that with dementia. If delirium was acute brain failure, dementia is more like a chronic brain degeneration. Dementia is not just normal aging, it's a pathologic loss of cognition beyond what we'd expect for age. It comes on slowly. Family might say, over the last year or two, grandpa has become more forgetful and confused. It's progressive, meaning it gets worse over time, usually steadily, though some forms can have stepwise declines if related to strokes. There isn't the hour to hour fluctuation you see in delirium. Instead, it's a long term change. In dementia, a person's memory and thinking ability deteriorate to the point that it interferes with daily life. Early on, short term memory loss is common, like they forget recent conversations, appointments, or they ask the same question repeatedly because they don't remember the answer you just told them. With diseases like Alzheimer's, this short term memory issue is a hallmark. The pathology tends to start in the brain's memory centers. Over time, other cognitive domains are affected. Language, finding words becomes difficult, executive function, planning, making decisions, spatial abilities, getting lost in familiar places, and eventually even basic functions, dressing, eating. Personality and behavior can change too. Someone might become apathetic, or in some dementias, socially inappropriate or agitated. There are various causes of dementia. Alzheimer's disease is by far the most common. In Alzheimer's, abnormal proteins build up in the brain, leading to neuron death. It typically starts in the hippocampus, the memory area, which is why memory loss is often the first symptom. Another common cause is vascular dementia, caused by multiple small strokes reducing blood flow to parts of the brain. These patients might have stepwise decline and more focal deficits, like maybe some weakness or slowed thinking. There's Lewy body dementia, which is associated with Parkinsonian symptoms and vivid hallucinations early on. Frontotemporal dementia affects younger patients in their 50s or 60s often and causes big personality and behavior changes early. But for our purposes today, we don't need to deep dive into each type. Just know there are multiple causes and patients might have a mix, like Alzheimer's plus vascular changes. Crucially, unlike delirium, dementia is typically not reversible. We can't cure Alzheimer's or most other dementias at this time. There are medications, like Donepezil, that may slow progression or temporarily help symptoms, but nothing stops the disease. That means if someone has established dementia, our approach is about supportive care and ensuring safety rather than trying to fix their brain. However, and this is important for EMS, a patient with dementia can also get delirium on top of their chronic dementia. This is called delirium superimposed on dementia. In fact, having dementia is a risk factor for delirium. If a patient with dementia becomes acutely more confused or altered from their usual baseline, treat it like delirium until proven otherwise, because they can absolutely have an acute medical problem too. In summary, think of dementia as a baseline chronic condition. These patients usually are alert and can have a conversation, but they are confused in their orientation or memory, and it's long standing. You won't fix their dementia in the field, but you need to know how to interact with them and also stay alert to any acute changes on top of it. Let's take a step back and touch on what's happening in the brain with these conditions in simple terms. We won't go too deep, but a little pathophysiology helps understand why patients act the way they do and why certain treatments work. For delirium, the brain's hardware, its structure, is usually okay, but the software is malfunctioning due to some insult. The exact mechanism of delirium is complex and not fully understood, but research points to problems with the brain's neurotransmitters, its chemical messengers. Two key players are acetylcholine and dopamine. Acetylcholine is critical for attention and memory. In delirium, we often see a deficiency of acetylcholine, for instance. Many meds that block acetylcholine, like some antihistamines or bladder meds, can trigger delirium. Meanwhile, dopamine is often in excess during delirium, especially in hyperactive delirium. This is why giving a dopamine blocker like haloperidol often helps calm a delirious patient. It counteracts that excess dopamine effect. Think of delirium like a chemical imbalance causing a brain network failure. The arousal systems, like the reticular activating system that keeps you alert, and the cognitive systems are not coordinating properly. The result? Fluctuating consciousness and confusion. Importantly, if we fix the underlying cause, clear the infection, correct the metabolic problem, these neurotransmitters rebalance and the delirium usually resolves. The brain reboots back to normal because we didn't destroy any parts of it permanently. Now, dementia, particularly Alzheimer's disease, is very different. Here, the problem is with the brain's hardware. The neurons themselves are being slowly destroyed. In Alzheimer's, two misfolded proteins called beta amyloid, which forms sticky plaques outside neurons, and tau, which forms tangles inside neurons, accumulate in the brain. Think of these like gunk that builds up in an engine. They interfere with how neurons communicate and eventually lead to neuron death. This damage tends to start in specific brain regions, notably the hippocampus, deep in the temporal lobes, which is crucial for forming new memories. That's why short term memory goes first in Alzheimer's. Over years, the damage spreads to the cerebral cortex, including the frontal lobes, affecting decision making and behavior, and parietal lobes, affecting spatial awareness, etc. By late stages, so many neurons have died that the brain actually shrinks. On an MRI, you'd see enlarged ventricles and more space in the skull. Unlike delirium, this isn't usually fixable. You can't magically regrow those connections, at least not with current medicine. We can only manage symptoms and try to maintain function as long as possible. The image shows a comparison between a healthy brain and neurons on the left and an Alzheimer's brain on the right. In Alzheimer's, you can see the abnormal plaques, brown clumps, outside neurons and tangles, twisted fibers, inside the diseased neuron. Over time, these changes lead to loss of neurons and brain shrinkage. A quick note on regions. The hippocampus in the medial temporal lobe is key for memory. It's like the brain's save button for new info. That's why Alzheimer's patients forget recent events first. The frontal lobes handle reasoning, judgment, and behavior. Damage there, common in later dementia or in frontotemporal dementia, leads to poor judgment, socially inappropriate behavior, or apathy. The reticular activating system, RAS, is a network in the brainstem that keeps you awake and alert. In delirium, often something is interfering with the RAS or its connections, like toxins or metabolic issues, leading to fluctuating alertness, sometimes almost unconscious, other times awake and agitated. Understanding these basics helps. For example, knowing acetylcholine is low in delirium and also low in Alzheimer's, since those patients have less acetylcholine to begin with, reminds us that certain drugs, like Benadryl or benzodiazepines, can really worsen confusion in an elderly patient. Or knowing that an Alzheimer's patient literally can't store new memories properly helps us empathize with why they keep asking the same question. It's not stubbornness, it's the disease. We will wrap up the current discussion here. The next one in this series, we will dive further into the assessment of cognitive disorders and how we can manage them in the field. See you then.